glad to be part of this session put together by the Healthcare Leadership Academy. It's a great honor and a privilege to share with my colleagues and people who have significant interest in the growth and development of healthcare in Lagos and in Nigeria at large. I'd particularly like to recognize Dr. Tayo Lawal, former Permanent Secretary, Ministry of Health, Lagos, Primary Healthcare Board, Lagos, and it's currently SA on Health, Ministry of Health, Ogun State. Glad to have you here, sir. Basically, we'll be talking about how and where we are, how we'll get to the next stage of our healthcare development in Lagos and Nigeria, the very key things that we need to consider, the opportunities that are available in the healthcare space, the critical conversations that we need to have, particularly with development partners and with people who are interested in making things work the way they are in Nigeria at the moment. Also, we need to talk about how to build resilient health systems, how we will add flesh to the skeleton that we currently have, how we can be deliberate about making our systems stronger, how we are setting up different facilities to make sure that the diseases and the very key things we've been dealing with over the years are put under control. Slides ready now?
In a bit, please.
A bit, okay.
Beg your pardon. So
the core really is talking about understanding and leveraging health financing for system strengthening. Financing is a core part of every government. And as we know that whatever it is we will do as a government or as people in Nigeria, the development and the success of our health systems will only come from local capacity. It's going to come locally. 95% of whatever efforts that will be put into developing our health systems that will make it stronger will come from local resources. So we cannot outsource our solutions. We cannot outsource the very critical things that we need to do, the very important steps we need to take. Cannot be outsourced to development partners. And we really will develop our own space by our own self. So on the back of this, we need to then look at the very key points. So there's something called, or there's a treaty called the Abuja Declaration, right, where countries came together and agreed that about 15% of their spending should be in healthcare, of their budget should be targeted to healthcare. It's not been very easy, to be honest. In Africa, about 3 to 4 countries have been able to comply over the past few years. Nigeria is still quite far from it. In terms of budgetary allocation, for 2022, we have about 5%. In 2021, we had somewhere around 7%. And it's interesting to note that over the past couple of years, it has not exactly hit 10%. What I can deduce or infer from that is our economy has grown, over time, but the healthcare landscape has not exactly grown to in that same pace. So that means that while we're developing in tech, while we're developing infrastructure in other areas, we may not exactly have expanded or developed enough in healthcare. So development is not just in the government sector, it's also in the private sector, So you need to pay attention to the private indices and, what we do in the private sector. And that's how you can make sure that, development currently definitely gets to, oh, do we have the screen now? I think so.
I think it's showing now. Just give me a second
I think it's just going
to load properly. Can you see my screen now?
Not yet.
Okay.
Not yet. It says you have started sharing screen, but
okay.
I can't see it. Okay, it's loading now.
Okay.
Okay, so first slide, I think I've given basic introduction. So the second slide talks about healthcare financing and how it provides the resources and economic incentives for operation of health systems. So these incentives form the key determinants. They are the bedrock on which health systems stand. Now, so when you talk about health systems, we'll be looking at things around equity, accessibility, efficiency of our systems, and then our health outcomes. So the efficiency, for instance, is particularly of importance to me, pretty much everybody, because of what use is having a system that is not able to meet standards or that is not able to live up to its expectations. So health systems efficiency is an area that I think that we need to pay particular attention and make sure that we make things work. So financing in the healthcare space has a very key role to play in efficiency, equity, and overall health outcomes. Also, as a critical development component, if you please go to the next slide, there's some
Okay.
things that are supposed to show.
Okay.
Yeah, that's it. Next one.
Okay.
So as a critical, previous please, I need that last line. Yeah, the second point, just before this.
This.
Yeah, perfect. So as a critical component like food, shelter, and clothing, the health sector requires and deserves adequate funding. It varies, funding varies across different countries, but I think I had made a note earlier that at the end of the day, the funding you require or the funding of any system is going to be massively from local sources. You're not going to totally depend on foreign support you can have is going to take up maybe like 5 to 10%, but we need to create resilient systems ourselves. Next slide. Okay, so in Nigeria, the financing of the delivery system is majorly through tax revenue. So that means that government pays for most of the things. Government will build federal medical centers, government will build general hospitals, government will be the ones to build many of the things we need to put together to make sure that our hospitals run, our healthcare systems function properly. Again, we also have a lot of out-of-pocket payments for user fees. It comes to up to about 70%. A lot of people still pay out of pocket for healthcare. The insurance sales and purchase in Nigeria, health insurance sales, is not exactly excellent as we speak. We have some donor funding. We also have some social health insurance. All of these things come together to form the bedrock of the financing that we currently have in Nigeria. Next slide, please. So there are some very key things that are the fulcrum. They are the things that hold health systems in place. The very first one is service provision. So service provision really talks about how you want to get to a hospital and have doctors there, how you need vaccines and you can go to the primary health centers, how you need everything, and then you need to have these services delivered to you at different points in time. The supply chain in the healthcare system is also a very key component. So the service provision is key, resource generation is key, financing the health system is also key, and then stewardship. Stewardship would include the actual commitment that the ministry or the healthcare agency, commits to this process, the administrative component of it, the kind of work that people do at different levels of healthcare support and strategy is part of the stewardship. The financing is what we have been talking about all the while. It's also important to note that for funding and for making our health system stable, really, there's a bit of a discord between where money should go. So health system strengthening, while it is key, most of your funding would want to go to disease-specific funds or want to be disease-specific funds. And then donors will most likely want to have some population-specific interventions. But the bedrock of all of this is that your health systems must be funded. Your health systems must be strengthened. There are very critical gaps. Like I said earlier, the Abuja Declaration says that the government should do about 15%. Currently, we don't have up to that. As we speak, the 2022 budget talks about giving health about 820 billion out of the almost 16 trillion budget that we have. Last year, the budget was about 13 trillion. So it's grown by another 3 trillion. But the commitment to healthcare has not increased that much. Like I said earlier, I wouldn't think that it is mostly because we don't have incentives or we don't have things to do. I think it's mostly that our health systems have not exactly expanded. We don't have much more to commit to insurance. We don't have much more to commit to infrastructure expansion and things like that. Also important to note that most of our expenditure is about 70% of it comes from people. It comes directly to the hospitals or to wherever the service is being offered, pharmacies and all of those people, traditional medicine practitioners and all of that. Next slide. So there are some very critical gaps that I think we need to note. The Article 3.8 of the Universal Health Coverage speaks to financial risk protection of the people that you're serving. So while people pay out of pocket, it's also very important that we're able to create that protection for them. And that's why we have very, very, very important things like the health insurance that have come up, very key interventions that are helping us shield the people from paying out of pocket. I give a quick example. You have very many people who are low-income earners, but suddenly have emergencies and they cannot pay the kind of money they would require out of pocket. They have an accident on the Third Mainland Bridge, for instance, and they are taken to a private hospital because they didn't get an ambulance or something on time. And then the bill comes to about 50,000. Without an insurance, you will just end up, wasting time and then begging the hospital to let you go. So that article that talks about protecting people, that talks about a financial risk protection, is one very key thing that governments have paid attention to, and they need to continue to pay attention to. So the very key components of our health financing models in Nigeria would be the National Health Insurance Scheme. Sorry, that's supposed to be NHIS. We have some social insurance and then private insurance. So private insurance mostly speaks to all of the insurance we have with the likes of the private companies. Most of the people who work in the private sector get these kinds of services because it's supposed to be compulsory for private sector players. Next slide. So while we have admitted that these models provide a general framework for classifying health systems, they are not useful in very small micro policy perspectives because every model is different. So what we have realized is that you have a general perspective of what should be obtainable. But at the end of it, the bedrock of it is that every single place is different. The kind of health insurance that you would adopt in Lagos, for instance, where you have a lot of metropolitan activity, and then you have a lot of people earning salaries, a very good population of people earn salaries at the end of every month, may not be applicable in a place like, say, Jigawa or Kano, or even nearby Oyo State, where most of the people earn daily income. So while you are creating a global or a general solution, you need to modify them to suit local perspectives and local needs. The key health policy issues are not whether government uses general revenue, but basically the amount of money that is able to go into healthcare, which is why the 15% would have been a very great thing, But even on the state level, it's not exactly happening yet, and except for one or two states, but it's not exactly happening yet. So similarly, nothing is inherently good or bad about public versus private ownership and provision. It is whether the system in place ensures access, equity, and efficiency, like we said earlier. So basically, if we're going to leverage the financing models that we have and push it to strengthen our systems, there are three key things we need to look at. So we'll get next slide, please. Next slide.
Sorry, I think it's hanging a little bit. Okay.
Okay. So to leverage the health system financing for this strengthening, we need to focus on particular things. First is equity. Equity is all of the things we talked about earlier. All of the access. I mean, everybody needs to get access to good health care. Whether you're rich or poor, whether you're a bank MD or you're a security guard, you need to get access to good health care. You need to be able to access quality care at different points in time. You know, efficiency is one very important thing that I don't think that our systems currently pay attention to. So it is one thing for the service to be available. It's another thing to have efficient services. So over the past year and a half, I have made particular note of things around health systems efficiency, making things work really. And I think the fulcrum on which our doubts about our health system stand is primarily about efficiency. So basic things like waiting time in the hospital is not an efficient way to run a hospital. Things like how you want to get pre-hospital care. On paper, we have ambulance services. Even on the federal level, we have ambulance services, but are they actually efficient? You know, so those are very, very important considerations. Those are very important things that we need to really start talking about. You know, the fact that our systems need to be more efficient. So if any conversation will go around health systems, is going to be talking about efficiency, the efficiency of our health systems, and how we can make sure that, you know, they deliver what they have said they will deliver. So again, it's quite a passionate point for me, because while we can put a lot of money into equity, and rightly so, I mean, everybody should get access to good healthcare, you don't exactly find efficiency in the public sector. You don't exactly find efficiency in places where 70 or let's say 50% of people go. You know, in the particular hospitals where you get tertiary and secondary care, most of the hospitals in the private sector provide primary, then some of secondary. But the place where you get the critical services, we don't have efficiency driving it. So health system strengthening should actually pay a lot of attention, and our efforts towards strengthening should pay a lot of attention to efficiency. Outcomes, very important. So it's one thing to say we're able to deliver every woman who is in an emergency, or we had zero mortality in our secondary health facilities, you know, from childbirth. It's also very pertinent to note that these outcomes have to circulate, they have to be global. So you can have a lot of general hospitals. If one of them is doing well and the other is not doing well, overall your outcomes will be poor. And that is, I think that is particularly what affects our numbers in Nigeria, you know, because while we're able to support ourselves in some urban areas, mostly in the rural areas, the outcomes are not very good. So it dampens the effect. So the outcomes are quite important as well. Next slide. Next slide.
Okay.
Right. So this slide is supposed to really just talk about the very core of system strengthening. You know, so at the end of the day, it's all about the people. The very key components that matter to the health systems are the things around these circles. So information is important. Governance, the governance of our health systems, medicines and technology, our methods, you know, how we bring drugs in, the technology of the health technology that we currently have, whether we can do keyhole surgeries yet, even adoption of electronic records, you know, things, simple things like that are very core to system strengthening. They help you make decisions, research, and all of those kind of things. Human resources, there's obviously, you can't run a system without the people, So at the end of the day, the brain drain and all of those things that are predominant in the health sector now affect the strengthening. So at some point, you have an influx of people to some areas, or to particular places where the pay is better. Then service delivery. We talked a lot about service delivery, how it has to be efficient, how the outcomes have to be better. Financing, we've talked a lot about it. Like I said earlier, information is something very key. Some people do not even know. So information is a very core part of health promotion and health prevention. Those are the core considerations in primary health, So next slide. Right. Like I said in the previous slide, I just wanted to throw a bit more light to it, So the key things that are very important, and this is important for people who are in a way particular about strengthening systems in different areas. I know a couple of people on this call work in the primary health systems, and the primary health systems, as small as they are, in the primary health care sector in Lagos, for instance, as small as it is, it goes a long way in, formulating what we see on a global scale. So governance, how you need to involve civil society, how you need to decentralize your communication, your activities, and your advocacy, licensing hospitals, accreditation of hospitals, registration of facilities, financing, key things like user fees. There's demand and supply side for cash transfers. Some people adopt these methods, particularly in the north. There's health insurance, there's provider financing model, statewide approaches, and basket funding. This slide will be particularly useful for people who are in governance or people who are in decision-making positions who would like to pay attention to one or two key keynotes that might help pay, the required service to each of these areas. For medicine and products, for instance, we need to pay attention to pharmacovigilance, because one key thing that we have noticed is that we get in fake drugs very easily in this part of the world. Why is not a question I can answer, but very importantly, at some point we had a very efficient pharmacovigilance structure, but on a local level, even in the community, community leaders might want to pay attention to the kinds of drugs that are sold in their pharmacies, create new approaches. It doesn't have to be central all the way from NAFDAC, supply chain management. This is a point that really hurts, because for me, I have understood that the supply chain in healthcare is not particularly owned by the healthcare structure or the governance structure of the healthcare systems. So majority of supply chain management in healthcare is done on the streets of Idumota and Onisha. So most of these people do not exactly understand the components. They don't have the structured, arrangements that should be in place. That is why a lot of things can go unchecked. So service delivery, health sector reforms, district health strengthening systems, these are very key components of health system strengthening. And I think that all of these things, as simple as they look, they are quite important in decision making. They are quite important in making sure that our health systems work. Next slide, please. I'll be done in a minute. All right, so speaking of funds from outside, if you have noticed, I'm not particularly excited about what comes from outside, So my mentor really, and he's the Commissioner for Health Lagos, Professor Kambayomi, he says a lot of the time that the problems of Africa will be solved by Africans. At the end of the day, whoever is giving you vaccines or whoever is giving you drugs has something to benefit from you. He's already asking for something else. It's a give and take model. Nobody is stupid with their money, and no money is free anywhere. There's no free lunch anywhere. So while we can get donor funds and while donors play key roles in helping us address some of our issues, while donors can contribute and put a lot of money together to solve some of our problems, it is also important that we understand that our problems are going to be solved by our own local capacity. Pharmacovigilance, for instance, is a local thing. You know, governance structure, decentralization, they're all local solutions. Majorly, what you can benefit from outside be funds. There's human resources, and there's a common saying that money doesn't solve. I mean, the answer to every problem in healthcare is not money. For instance, you increase salaries of health workers. It doesn't mean that the salary is not what they will save to leave Nigeria. Actually, the people that pay the most just help them save money to live. So maybe money is not the only solution, and there are very many more solutions that we can get from within, and that have helped us over time. Next slide, and which is supposed to be the last slide. So the global health financing policy is in transition. A lot of money has come from large grants from very many financing entities, and it has changed and shaped the world of global health policy. But then, over and above, decisions made by the World Bank requires that financing basically will come from local sources, and it has pushed local low-income countries to develop their own health policies in the context of an overall strategy framework for poverty reduction. All of this would include or would involve an intersectoral participation, and then you'll have to trade off a couple of things for others. In conclusion, personally, I would say that over time, we need to deliberately build our systems. No matter how much of help we get from outside, it doesn't totally solve the problems. We need to leverage our financing models, our local financing models, and pay more attention to strengthening the systems. Yes, finance is a core part of the system strengthening, but it is not the only part, and it is probably not the most important bit of system strengthening. Thank you very much. I would like if you leave the 10th slide that has the table on, and we can have further conversations and questions. Thank you.
All right. Thank you so much, Dr. Ajayi, for this rounded presentation and the insights you've shared. I, for one, have been writing so furiously, just taking down notes. I believe that this has certainly provided several takeaways today for everyone who's joined in, regardless of the spaces in which they work in. And so I want to thank you once more again for this very key, insightful presentation. So off the top of my head, while I wait for us to share our questions in the chat box, we'll take them in the order which we receive them. I'm just thinking, because you said a lot about, although your last point of statement sort of changes the direction in which our thoughts, are around health financing and system strengthening. However, if we're just looking at the role that health financing plays in system strengthening, how essential the component it is in ensuring universal health coverage across access to care or service delivery or financial risk protection. The question is, where do we go from here? Because when you say we should think about how we can leverage our local capacities, our local sources, local mechanisms, what are the practical ways in which we can start to turn this conversation? What are the practical steps, either in the public sector or in the private sector, we can start to take to actually, what are the policy, what are the actors we need to speak to? These conversations, how do we move them from a need to have to something that is currently in operation, something that's working?
Okay, so
I know that was a mouthful, but I hope you got the point.
Yeah, I get your point. And
all right,
this is my very quick answer to it. There's a reason I asked that we leave that table on. I think that health financing is very key. I mean, it helps you solve a lot of problems. But overall, the next steps should be for particularly people that work in donor agencies and people who support governments in making decisions and help with policy, is to pay attention to the other building blocks of health systems strengthening, right? So yes, we can leverage health financing, but strengthening the system has other components that are very key, that are as important as health financing. Let us leverage the finance. And then next steps would be pursue governance. Make sure that there's a smooth way to license facilities, for instance. Accreditation of facilities or health facilities is usually not as straightforward and as easy as you think. How to bring in the civil society to have these conversations. When people know that, when people know that, not from me. No. All right. So going forward, let us begin to look at conversations around the very many components. Let's focus on health system strengthening as opposed to leveraging finance for disease-specific interventions. Very straight up. So most interventions are for HIV, tuberculosis, modern child care, and all of those things. Those are disease-specific. But the financing we get, or the financing that have been channeled to those things, should actually be used better to strengthen the systems, if you get where I'm going with this. Yeah, so you get a lot of the funding you get from everywhere is usually disease specific.
We ask that you kindly mute your mics.
Yeah.
Thank you. Sorry about the interruption.
Yes, fine. So, while we pay more attention, while we try to put all of these things together, should strengthening systems, our financing.
Let me see how I can move
They don't like it. They don't want anybody to forget. And the worst part of it is that the old ones that they are claiming, they always make mistake on that.
Apologies. Thank you.
Oh yeah. So I'm happy to take further questions, and then I can't see any.
Okay.
So I mean,
Okay.
if you don't have questions, I think that well, I hope that I have been able to share very key insights and show some light to how we perceive system strengthening, and then make things work overall for Nigerians. There's a question that says that.
Yes, I was just about to read it. So
Okay.
Franklin Deme, thank you for sharing your question. He says, my research has shown that Nigeria has an appreciable amount of primary health care centers, but people still prefer out-of-pocket payments, despite setbacks like low, longer waiting time and shortage of personnel. What do we do about this?
Okay, so for this particular thing, I mean, it's interesting. We have primary health centers across Nigeria, but people prefer to go out of pocket. So out of pocket payment includes how you go to a primary health center and they write you a drug that they do not have, and you have to go and pay for it, right? Because you are paying out of pocket. So it's not just about people not attending the primary health centers. Interestingly, in many areas outside Lagos and outside Nigeria, no, not outside Nigeria, outside Lagos and all over Nigeria, a lot of people, and enormous amount of people, use primary health centers. They are probably the most used. I mean, if you have a primary health center in an area, it's probably going to be the single most used, particularly in the low-income areas. But people still have to pay for a lot of their medicines out of pocket. So maybe we need to understand better that out-of-pocket payments doesn't just mean that you go to a primary health center and get it for free. Yes, you can get anti-malarials for free in primary health centers, but if you have to use antibiotics, if you have to get other medicines, because you do not have health insurance, because your financial risk is not protected, you still have to pay out of pocket. So PHCs do not exclude you from paying out of pocket.
Out of pocket payments. Fair enough. Thank you, Dr. Ajayi. Nana I says, if you have to choose just one component for health system sustainability, what would it be?
I think that I personally would pick, I would pick systems efficiency and maybe governance, because I know that if you have governance right, you will be able to solve many more problems. So if governance is well done, for instance, if the source or if the authority overseeing your healthcare understands many of the issues, then they can put medical products and vaccines in place. They can understand and properly manage the supply chain in healthcare. They can help you with human resources initiatives, things around why you should keep people here and why Nigerians should remain in Nigeria to solve Nigeria's problems. Why we shouldn't promote brain drain, as it were, irrespective of the current conditions. So if I was to pick one, I'll pick governance. I think governance oversees everything. Like they say, the leader dictates the tune or the tone of government and how things are run.
Absolutely, Dr. Ajayi. I really agree with you. And in fact, at the HLA, that's the Healthcare Leadership Academy, one of the things we've recognized and that drives our work is that what underpins the challenges in healthcare delivery can be attributed to management or leadership capacities. They say everything rises and falls on leadership. So I quite agree with you on that point. And I think that there is a lot to be said about developing our capacities, our governance, leadership capacities, so that we can raise, the next generation of healthcare leaders who excel in the governance of the healthcare system. Otherwise, like you said, we can throw a lot of money, we can devise strategies, but if the governance is not right, we'll be hard pressed to reach our goals and the national healthcare agendas. So I agree with you. Next question, someone says, okay, I think I skipped the question before that. Let me just quickly backtrack. Kelechi, thank you very much for sending your question. Kelechi says, how will you appraise the United Kingdom system vis-a-vis the United States system of healthcare financing? Is there a hybrid system we can deduce from these two great systems?
Oh, well.
What are your thoughts on that?
So my thoughts really are that the UK system is purely tax-based, it's mostly tax-based. So you pay a lot in tax, and that tax has an incentive, or it gives you that healthcare coverage that you want. The US system makes you pay heavily if you're not in the tax bracket, or if you choose not to pay for insurance. Is there a hybrid? I think our problems are different from these two. I mean, we're not quite there yet. And I don't think a hybrid is what we should be looking at, really. I usually am not the first person to adopt or adapt any kind of foreign solution. I always feel like our people are different. So how do you, I was speaking with a tax consultant earlier today, and all of the conversations were around how do you get more people to pay tax in a city where maybe 70% of people earn their living daily. So how do you go to the vulcanizer to say, oh, you have to pay tax every day? Interestingly, the local governments sort of have a way of using touts and all of those boys to collect the tax, but do the touts pay their own taxes? So because we are not tax-based, we don't have a very large tax bracket. We may not be able to use a hybrid of these two. I think that most of our local social insurance schemes, like what we have in Lagos, for instance, devised many models and ways of reaching even these people inside the market. So things like going into the market and actually selling it to them every month. So it's, for instance, it's about 850 naira a month. So if you can go into the market, you tell her, well, you do this today, and then it covers you for the month. At the beginning of the month, just give me 850 naira. Simple conversations like that. So that is not anywhere near what the UK does. If you are going to the UK now, your health surcharge, if you are going to stay there for more than 3 months, your health surcharge is going to be more than double your flight ticket, right? So you'd have paid ahead. So I don't think a hybrid is what we're looking at. I think we need to adapt our own solutions. And I think the individual states health insurance schemes have begun to look at these things. How you can tax the farmer, how you can tax the bus drivers, how the tax you collect from downfall buses can cascade into the health insurance scheme and make sure that it protects the downfall drivers who may have an accident at some point. I think those are key conversations that we need to begin to look at. Again, it comes back to leadership.
Fair enough. Thank you, Dr. Ajayi. One more question here is, how do we stem the issue of government medical practitioners neglecting the PHCs and focus on their private hospitals? Is there any policy in the works to address this in the light of improving efficiency?
So number one, there's a law that if you are a civil servant, you cannot own a hospital, right? So that's a key thing, and it is in the law. It is not, but it's not about having a law. It's mostly about mostly about how the law works or how the law is enforced. Secondly, even when the doctor who works in a government hospital also has a private hospital, or he runs a private practice, I don't particularly see how. Okay, let me restructure that. My answer really is that you need many more facilities to cover. However, so long as it doesn't affect the efficiency of the system where he works primarily, then it's fine. And I say this with all sense of understanding of the core issues, right? So again, we need to chase health system efficiency. It's an area where I'm very passionate and where I particularly like to pay attention and discuss. Health systems efficiency is very germane to our outcomes. It's very important. The human resource development is important to every single bit of the service delivery. Making our systems efficient and it's not just about the core health workers. It's about how an ambulance driver gets to work at the time he's supposed to get to work. Because there might be an accident at the time when he's delaying, and then that system will not be efficient for that particular scenario. So health systems efficiency is really an all-encompassing thing that helps you drive all of these things. So for me, if he's able to make his own clinic or his own primary service efficient, then if he does his clinic or his other job as a side, it's fine. There's nothing exactly that says that you shouldn't make money from other ways. But the law says that you cannot have.
I was just about to ask Dr. Ajayi if we could quote him on that statement. So he's gone back to say the law says we shouldn't. Okay, thank you, Dr. Ajayi. Miriam, thank you for sending in this comment or question. She says, when talking about strengthening healthcare systems and improving outcomes in the PHCs, you mentioned the new approach to pharmacovigilance as a key factor. But from my own observation of our health, I'm sorry, I'm trying to, okay, since from my own observation, I don't know if you can see from your end, okay, from my own observation of our healthcare system, that will be hindered without a proper hospital formulary in place and ensuring adherence to standard treatment guidelines. What's your take on this?
Right, so we have standard treatment guidelines, and pharmacovigilance is quite a key thing if we're going to be honest with ourselves. So I'll give an example, a quick example. You have NDLEA that's making the rounds now, and if you post any kind of random video of you smoking, they'll visit you before morning, right? It's also very key that we should have, because they have a local network, they have people that are informants. Another example, there's a building control agency, as it were, there's a building control agency in most states of Nigeria. They have local informants. They have people in that area who will see a heap of sand outside and notify them and say, you need to come and make sure that people are building according to specification. The same thing, if you have a local, I know there are local government health authorities, in the local government who should be able to monitor this, but then the pharmacovigilance bit of it is not a core of their services at the moment. So I think that we need to pay a lot of attention to pharmacovigilance. Again, it's a very dicey thing and it is very important. Imagine that a child has a cough and you go to buy an antibiotic, for instance, because you think that is an infection. And the antibiotics is primarily semo mixed with water. The child is going to get worse. So we need to pay attention to some of these things. And all of these things come back to system strengthening. So if you have funding or if you have finance for for the health system in Nigeria, as opposed to just doing HIV or just doing CB. Some of these small structures, like setting up a system or a team that monitors these kind of things in local government, will go a long way. And if you model it in one local government, before you know it, it's gone to 5, it's gone to 10. You catch people who sell fake drugs or who sell substandard drugs, you're able to escalate. You know, all of those simple things are the things that ensure that people in the most remote areas get access to good drugs and quality as it were. You know, so I think I've answered that question. Next one.
Thank you, Dr. Ajayi. I want to say thank you, Olusegun, and thank you, Michael, for sending your comments as well. Dr. Ajayi, can you just turn the conversation a little bit to talk about health financing policies? If we think that some form of design or implementation of context compliance or context appropriate health financing policies, like what you mentioned around, you know, some of our local capacities or like the insurance schemes.
Yeah.
So if the design and implementation of this context specific health financing policies can help to sort of address the conversation around health financing in our health system, what are the coordinated actions? And I'm asking this because I like to think about action points after every sort of conversation. So what are the action points that across our very multi-layered health system that need to be taken and monitored, you know, for effectiveness of these policies? Can we just turn the conversation a bit towards the direction?
Okay, good. So for context-specific funding, I mean, if you have funding for a project, I expect that there's usually KPIs, there's usually particular things that these things are supposed to address, right? So if you are supposed to, at the end of the day, address system strengthening, then you will look at the applicable key points to that context. For instance, if your intervention is specific to health insurance, right? Health insurance also has a very key component that includes governance. So if you don't have good governance, you can't have good policies to support what you're trying to do. So that funding should be very key. If you don't have good human resources, in fact, information is a very key component of health insurance, for instance. So people they don't understand what it is, you know. So disseminating this information at the local level, I'm keen on going local, because I realize that the problems actually are in the community, and that is where you can solve them. It is within the people, it is amongst the people who have problems that you can go and solve the problem. We can formulate and do all of the English at the state level and, you know, at the governance level, but right down there, I mean, way down, you realize that there's a lot more that needs to be done at the local level. So the key points, the key directions you need to go, you know, look for the task-specific points or the task-specific building blocks of your context-specific intervention. You know, look at the ones that are very important to it and then take them one after the other. And I'm sure that you'd be able to achieve a lot more than you expect.
Wonderful. Thank you so much for that answer. I'm so sorry. I know we're running out of time. Thank you, everyone, for your contributions to this conversation. It's been very, very helpful. Oladoyin is asking, is it not time for our governments to encourage local pharmaceutical companies to manufacture commonly used drugs that can supply government hospitals? I think that question will be for every one of us to answer. I think, is this Franklin? They're saying, we see cases where funds are provided to a CMD, but they are not used to adequately develop the government facilities. And then he makes reference, okay, this is just to piggyback on the conversation earlier, and then make reference to his own clinic where all the bulk resources are invested. Recently, I'm sorry, my what's it called, is skipping a little fast. So it says recently, a similar case was exposed online. Thank you so much for your answer. Okay, this is just a comment.
Yeah.
And I don't know if Dr. Adai wants to just throw any more light on that. Someone is asking which body is responsible for holding them responsible. So I mean, this
I think that these things are still go around. They circle back to what we've been talking about.
yes.
But I also know, I am very sure that there are a lot of local pharmaceutical companies that supply government drugs. I mean, there are many of them that produce drugs locally and supply government drugs. There are standards of production, and a lot of them meet the standards and supply drugs to government. However, there are still many more drugs we are not able to provide locally or produce locally. And then there's still competition, between imported drugs and locally made drugs, because at some point, the cost of production locally may not be efficient enough to compete with what they bring in from India or wherever it is they produce them. But then I think government has done a lot of work in terms of policy, in terms of incentives to encourage people to produce drugs locally. We just recently got announced as one of the production hubs for vaccines in West Africa. And I think that's a great one. It's one of the
amazing
results of one of the government push that we have had on this front. So I think that's great. CMDs and all of those things. I think that it's not that easy to run a hospital. With the amount of money you get from government or from wherever sources, running a big hospital on free healthcare or on the thinking of free service is not efficient, and it is not sustainable. So you'd be surprised that the subvention you get might just be sufficient to put diesel in the generator for the month. Again, you need to get more information before we can make such kinds of remarks. Yeah, so we need to hold people accountable. And my last statement is going to be that not every problem you see is because of corruption. I'm not saying there is no corruption, but there are problems that are bigger and fatter and larger and taller than corruption, right? There are core problems, issues around governance doesn't circle back to corruption. Issues around human resources. That's 5 doctors out of 7 or 8 in a general hospital leave for the UK. It's not corruption. It's basically just people making their choices. And then you get to the hospital, you don't have people to attend to you on time. The remaining 2 people are tired, So not everything is corruption. And I think that is important that we begin to take our mind or gradually just shift our minds away from they're stealing all our money, all they do is make money and all of that. It's not everything that is corruption. The issues are way deeper. All of these things on this table don't exactly go back to corruption. There are things that we can solve one at a time, if only we pay enough attention to them. Thank you.
Thank you so much, Dr. Ajayi. This has been such a pleasant, such a very, very enlightening conversation. I'd like to just reiterate or emphasize the fact that the Healthcare Leadership Academy remains committed, because one of the great important points or salient points that Dr. Ajayi mentioned was around governance and building leadership capacities. And the Healthcare Leadership Academy remains committed, to increasing these capacities among healthcare professionals, leaders across all the sectors, in our health system. We deliver a range of programs, capacity building programs for healthcare professionals. We invite you to please visit our website at www.hlafrica.org to get more information on courses that can help build, your capacity or someone within your network that you think will be of value and benefit to. Of particular importance or emphasis is our upcoming financial management workshop. We've shared some information about that in the chat box. This, will indeed help when we talk about governance and management of resources. This will indeed help you if you're an owner of a healthcare facility organization, to build capacity on very easy, adaptable management principles that can sustain the performance and health of your organization financially. Thank you so much, Dr. Ajayi. Thank you, everyone who has contributed to this conversation. We hope that everyone leaves this learning session, with a sense of commitment to learning and exploring new ways that we can all work together to advance governance and leadership capacities, both of health financing mechanisms, locally at our disposal, as well as, the health systems at large to improve care access and delivery. We really appreciate everyone who has joined us this evening. Let's keep these conversations going on. This session, you can, visit us online to just share possible suggestions of topics that we can also address as we work together to make our healthcare system better and improved. Thank you very much, everyone. Thank you, Dr. Jayi. It's been a pleasure to have you join on. Please join us on our next webinar. We appreciate you. Have a wonderful evening, everyone. Goodbye.